We have a special treat tonight. We're going to hear from one of Emory's experts on epidemiology, and he's going to talk about a really important topic, and that is epidemic models for projecting the COVID-19 global pandemic. It's something on all of our minds. It's timely, and it's important that we as an educational community understand these dynamics. We're fortunate to be at Emory University, where not only are we caring on the front lines for patients, but we also have researchers across the university who are working on trials and studies for vaccines and other studies that will help us understand this disease. Tonight, our speaker is going to speak for about a half an hour, and then we'll have plenty of time for question and answer. You can submit your questions by clicking on the question and answer box at the bottom and type those in, and we'll take them in order. And then if you have any problems with the broadcast tonight, you can use the chat box, which will go directly to our speaker, to me, and to Matt Smith, our fantastic academic tech guy who's driving our call tonight. So our speaker tonight is Dr. Samuel Jenness, PhD, who is an assistant professor here at Emory in the Department of Epidemiology in the Rollins School of Public Health. He is the principal investigator of the EpiModel Research Lab, where the research focuses on developing methods and software tools for modeling infectious diseases. Its primary applications concentrate on understanding HIV and STI transmission in the US and globally, as well as the intersection between infectious disease epidemiology and network science. Professor Jenness is uniquely qualified to talk to our topic tonight, and Sam, it's wonderful to welcome you to the Oxford College community, and thank you for being part of Emory, and thank you for being with us this evening. On to you.
Yeah, thank you, Dean Hicks, for the invitation, and for Zach for linking us all up together. So I'm going to go ahead and start sharing my screen and get started. Okay. So hopefully y'all can see that. Okay, and like Dean Hicks said, we'll go for 30 to 40 minutes or so talking about this topic, and then dive into some Q&A towards the end. Let me just make sure everything looks good. Okay. So the topic tonight is epidemic models for projecting the COVID-19 global pandemic, and the kind of organization of the talk is to introduce epidemic models, infectious disease models more generally, and also discuss how they're being used specifically within the coronavirus response. So exactly 1 month ago today, which seems like lifetimes ago, a projection by Mark Lipsitch, who is an infectious disease modeler and expert in respiratory infections at Harvard, projected based on a relatively basic model that up to 70% of the world's population could become infected. At that time, coronavirus had spread through China, and new emerging outbreaks in Italy and Iran were coming about, and the overall death toll had reached upward of 3,000 cases. And of course, it's much larger now, and the projections that Dr. Lipsitch's models were formulating projected both the case count, or the total cumulative incidence of disease across the world, but also the fact that a significant fraction of the cases could be fatal. And that's played out today. Things have changed dramatically over the past month, but much of the response within the United States has been driven by the release and dissemination of the so-called Imperial College model, which happened on March 16th, a few weeks ago. This fundamentally changed our response to the epidemic based on what was one of the first national US models in the country. And this report was led by Neil Ferguson, another leader in the field of modeling of respiratory infections, and his team at Imperial College in England. Some of the model predictions from this model for both the UK and the United States were dire. These included estimates of the total deaths and the case counts in these two countries assuming different scenarios. And the worst case scenario assumed that we did essentially nothing, changed no behavior, and had no biological prevention mechanisms, and that could result in upwards of 2.2 million deaths in the US. And this behavioral response was essentially what was the case even 3 to 4 weeks ago. So this is if we do nothing, but the model also showed some scenarios of what could happen if we did something. And the something that they modeled was different forms of case isolation, social distancing, and quarantine for different people in the population in different settings for a particular period of time that's highlighted in the purple band there. So if we did some of these behaviors, we could potentially lower the number of total cases and the critical care cases substantially. But what mattered really is how much above this red threshold line, this horizontal line, we'd be going under different scenarios, different behavioral change scenarios, where the red line is the critical care capacity for hospitals that we're seeing just within this past week has edged, we're edging closer and closer in places like New York. So after the report was released, the federal government, both at the CDC, the White House, and elsewhere, really changed their tune in terms of the messaging related to behavior that the public needed to engage in as a function of the potential severity and magnitude of the coronavirus outbreak across the United States. Many policies were already in place and beginning to be put into place in hard-hit cities like Seattle and elsewhere that were the epicenters of the initial outbreaks in the US, and also in organizations like Emory to prevent mass gatherings. Conventions and conferences were already being canceled, but this was really the first time that the general public was being warned to reduce their social exposure. And around this time, this new term, social distancing, entered the lexicon. This is a phrase that we had never had spoken within daily conversation before 3 weeks ago, and now everybody is talking about social distancing and towards the end of flattening the curve. And the flattening the curve is this mechanism of spreading out the number of infections over time. So reducing the peak incidence below this healthcare system capacity, such that the healthcare system and providers can respond to this emerging disease outbreak. But for how long do we have to flatten the curve? How long are these behavioral changes needed? Around this time, there were a number of public interactive models like this one shown on the New York Times website and developed by some researchers at the University of Toronto that allowed for some interactive evaluation of different scenarios of how long social distancing policies or reducing contacts over time would have to occur. And based on this, there was some discussion among different politicians about how quickly we could return to normality, maybe as soon as Easter, and maybe a little bit of a longer term roadmap to reopening America that entailed doing this for several months. Okay, so we know that some form of social distancing was recommended, and it is potentially having a substantial impact on the case counts, but how long do we have to do this? And these interactive models really depend on how long we're running the models out for. So if we extended the x-axis from even the social distancing model where we're changing behavior for 2 months out for even longer, we can find that these infections are potentially going to reemerge at a later date. We're not erasing the infections, we're just delaying them. And if we're extending the peak of the incidence to the winter months, things could be even worse in the case that there's some interaction, as there is for seasonal influenza, between temperature and the incidence and severity of disease. So this was also predicted in the Imperial College report too, not as highlighted as much as the primary findings of what we need to do over the next couple of months. But this reemergence of cases that could happen as soon or quickly after that we stopped these social distancing policies or other types of isolation policies is a key finding of the report and a key projection of not just this model but of many models. And according to Dr. Ferguson, who is the developer of this model, he said that we don't really have a clear exit strategy based on these recommended measures. We're going to have to suppress this virus, frankly, indefinitely until we have a vaccine, until we have some sort of biological or clinical mechanism to prevent the virus. So the outline for the talk today is to introduce to you what these models are, how they're built and analyzed. And the first two are going to talk about models in general, and then move into speaking about how the models have specifically been used for the COVID response. And then wrapping up with how then the models that have been developed by scientists are then translate and percolate into the news and public health policy environments. So mathematical modeling plays a very critical role within epidemiology. Much of epi is focused on the relationship between individual exposures and individual outcomes, usually informed by a single data set. But infectious diseases break many of the standard epi rules, and some of these are listed here. We care about not just disease acquisition, but also transmission. We are interested in the dynamics that happen over time as a function of contagion, so like exponential growth of epidemics over time. We're often concerned about not just individual outcomes, but population outcomes. We're working in the context where we need to synthesize systematically multiple data sources under a lot of uncertainty instead of working with one data source. And we often are needing to do some future projections of different counterfactual scenarios that we don't have direct and immediate data, empirical data to support. And the workhorse behind much of traditional epidemiology is the statistical model that functions something like this. We collect some data based on our research questions, maybe height and weight, and these are the red dots in the plot here. Choose some functional framework for summarizing the data, such as a line, a linear relationship. Fit a regression model to estimate the parameters of that relationship. So say to find the slope between height and weight, and then potentially infer population association or causal effects of how one thing affects the other. And often we are making assumptions about the temporal stability of our findings. So what we collected data on the past year and what we analyze today applies to behavior and phenomenon and things about the world tomorrow. In contrast, mathematical models, which I'll use as a synonym for epidemic models as well, start with the parameters and theory instead. And they construct mechanisms to get us from the micro level to the macro level in many cases, where the micro is individual level biology, behavior, demography, or other features. And the macro level, what we want to end up with are some features of the population, usually something to do with disease incidence and prevalence. The temporal instability of these model outcomes is inherent to the models. And it's of interest. We care about how things change over time and how rapidly they change over time. And I'll show you the primary mechanism for that in a second. We can also estimate scenarios in these models, bringing together parameters and theory that are not present in empirical data, as long as they're supported by theory, as long as we have some basis for thinking about them. So the nonlinear nature of these systems and these models is driven by what I call the epidemic feedback loop, in which the individual risk of disease is driven by the prevalence of disease in the population. So even if we assume that nothing changes in the population with respect to behavior or biology, prevalence goes up and down, and so individual risk goes up and down with it. And this depends really on the ratio of susceptible, infected, and immune people in the population over time. And this ratio changes as new people are becoming infected, the incidence that leads to changes in prevalence, and that leads again to changes in risk. So if some of these components, such as biology or behavior, do change over time, we still are interested in using models to understand how this percolates up to the population level, because it's not just a linear scaling process. So mathematical models are often also called mechanistic models, because what we build into the models when we're pulling together parameters in theory are the unique structure of mechanisms that get us from a set of inputs and a set of outputs, where the inputs are something about, say, individuals, and the set of outputs are, say, something about the population prevalence or incidence over time. And these mechanisms, as we map out the models and we build these mechanisms into computer simulations, represent the unique set of pathways by which the inputs are affecting the outputs. And we can ask the questions, given all the inputs and all the set of hypothesized gears fitting together, what do we get at the end? What the gears do and how they fit together has to be informed by many areas of science. And as I'll show you towards the end for COVID models, this is really drawing upon quite a broad scientific background. Another metaphor for models are maps. Models like maps are an artificial representation of reality with different levels of abstraction. So we might use one map at a particular level of zoom to get us from Washington, D.C. to Atlanta, and another map zooming in further to get us from one side of Atlanta to the Emory campus, and another further map to get us from one side of the Emory campus to the other side of the Emory campus. And the map that we choose, the level of zoom that we choose within the map depends upon what we need to do, where we want to go. And that really, that usefulness, that utility value depends upon our scientific question. And so the level of zooming in and out of the map might change depending on that question. Models are also a virtual laboratory as well that allow us to test different questions in our computational petri dish, to push different levers and see what happens, given the fact that we're often working in a data constrained environment where we don't know what's going to happen in the future. Our outcomes are unmeasurable. And we often have sparse data on what we can do today. So what is feasible in terms of the counterfactuals or the exposures, these what if questions. We don't know what's potential. So there are lots of models, and there are lots of categories of models, and there's probably lots of classifications of those categories of models, but here are three broad categories of models in my reading. People can be in, and track the speed of transitions across those disease states with what are called differential equations. And I'll show you an example of that in a minute. These models are analytically tractable, but often limited for representing some transmission processes. Agent-based models, instead of representing groups, represent individuals within the population and use algorithms that have some randomness or stochasticity to them to track those transitions across the states, usually coming up with some special algorithm for how individual agents within the computer simulations come into contact with each other. This provides some more flexibility in representing the heterogeneity within the population, but it often is challenging to simulate realistic contact processes. And finally, a class that I would call stochastic network models, and this is the area that I do a lot of work in the field of HIV and other sexually transmitted infections, also represents individuals within the computer models and has a rigorous statistical model background to represent the contact process. This provides some more flexibility and rigor, but also requires some primary data on the network structure that might not be available, and also some extra computational resources. So that's what epidemic models are. How are they built and analyzed? Well, let's go to a foundational principle of infectious disease epidemiology that you've probably seen quite a bit of in the past few months. It's called R0. which is defined as the average number of transmissions that result from an individual in a completely susceptible population. So as shown in the graph on the plot on the right here, if we have one infected individual and we have an R0 value of 4, that individual is going to transmit to 4 people, and each one of those 4 is then going to transmit to 4. So after 2 generations, we have 16 infected people in the 3rd generation. This is formally defined as representing something about times 0. So this completely susceptible population. That's why the little 0 is there in R0. But in practice, we often talk about R0 4 times 0 and after 0. The critical threshold for R0 is 1. So if R0 is above 1, then we're going to have an outbreak because we're going to have a cascading or exponential growth of new cases. And if R0 is less than 1, a single individual is going to transmit on average to less than 1 person, then the disease will shrink. So R0 answers this question: how many people will a single new infected person infect during the case of their infection, either at time 0 or potentially later? So how do we calculate this? Let's go through a heuristic example, and then I'll show you how this maps onto a mathematical model. So say a person Z walks into a town, and it's otherwise closed population, so there's no migration, with a case of a viral infection like coronavirus. And they shut the gates. And in this town, people have on average 4 contacts a day. And contacts, we don't really know what that means, but let's just assume that we do for this exercise. And then during each contact, there's a 50% probability that the infection could be transmitted. And the total infectious duration of having that disease in the infectious period is 10 days. There's no latent period, say in this example. So what's the total number of contacts that Z has while infected? Well, it's 4 per day times the total duration of infectiousness, so 40. What proportion of those contacts will be susceptible to infection at time 0? Well, at the very beginning, 100% of the population. So what's the total number of susceptible contacts that Z has? It's going to be 40, 100% of 40. And then for each contact, what's the probability of transmission? 50% from above, and we'll represent that with that parameter that we'll call tau. So what's the total expected number of people that Z will infect? Well, we can just take the product of those 3 parameters, tau times C times D, and come up with that expected number, or 20. And that's the formal, or that's the heuristic definition of R0. That's how we get to R0 in one definition. So we can then map some of these parameters that make up R0 directly onto epidemic models and how we build those models. And principally, the most important parameter that we care about is the force of infection, which represents how people become infected over time. This force of infection is a per capita risk or rate of a new infection for each susceptible person at a particular point in time. It extends R0 past time 0, and it asks what proportion of those contacts will be susceptible to the infection, not just at time 0, but at time 1, time 2, time 3, and so on. So this parameter, lambda, can change over time because this proportion of contacts that are susceptible also changes over time. So this general formula might be represented in this in the simple equation, the transmission probability times the contact rate times the number infected over the population size. Or that's another way of saying the disease prevalence at a particular point in time. And that changing parameter really drives much of the temporal nonlinearity of infectious disease models. Then we also have a parameter for disease duration, right? We have an average disease duration of 10 days in our toy example. Then using some common statistical assumptions, we can say that 10% of the population will recover at any given day. So 1 over the disease duration, we would say, is the recovery rate. So then we can take these parameters and fit them into a model that represents how people are moving across the particular disease states over time. So say we divide the population simply into 3 disease states: susceptible, infected, and recovered over time. And we want to use a model to track how big the size of those compartments are over time and how quickly people move from one compartment to the other. We could have the compartments completely closed, or we could have some sort of extra inflows and outflows that might represent things like births and deaths, as well as we do in this diagram here. So the model equations on the right are really mapped onto what you're seeing in the plot on the left. and they're tracking the inflows and outflows from the different compartments as they're possible over time. These so-called differential equations specify how fast things in the numerator change over time in the denominator. And the things that we care about tracking are the rates of change in the compartment or state sizes over time. And we come up with the answers to these equations based on what's on the right-hand side of these equations by multiplying the parameters, or the rates that we talked about two of in the previous slide, times the sizes of the size of the compartments, the number of people who those rates apply to. So the compartment sizes over time are these nonlinear functions of the inflows and outflows. And why, again, are they nonlinear? Well, I showed you that they were nonlinear because of the epidemic feedback loop. And why are they nonlinear in terms of the math? Well, specifically because the variables on the left and the right-hand side of the equation are possible. Okay, so the number of susceptible, say the D of S, can be a function of the S on the right-hand side of the equation too. And that's just another way of saying the incidence depends upon the prevalence. Okay, so this is the feedback loop again. And what do we do if we don't have certainty about those parameters, and in particular the contact parameter, which we just assumed that we knew as 4 per day, given the fact that many parameters are uncertain. And they're especially uncertain for respiratory infections like coronavirus, because we don't know what types of contacts are effective for efficient disease transmission. There's lots of hypotheses and good bench and clinical science to back it up, but there's still a huge amount of uncertainty. The social contact patterns are very different in different populations, and the intensity of the contact that's sufficient to transmit these pathogens is often known. So what do we do in this case if we don't have a single number, a single fixed number to represent these parameters? Well, there are two potential approaches. Well, there's lots of potential approaches, but here are two. One is called model calibration, where we test out different parameter values for things like the contact rate and see which are more consistent with some external data. So say we have some measurement of the epicurve, these little red dots here, and we can run lots of simulations from our models that are consistent with the disease structure that we're interested in, and test out different parameter values that are better or worse fits to those dots. On the other hand, there's sensitivity analyses, which take a given set of parameters for the model across different ranges and ask the question of how much do the conclusions depend upon the choice of those parameters. So we might not get a single value, say for the reduction in incidence, but a range of values that are all consistent with the data. So those are the inputs. What about the outputs? Well, there are lots of potential outputs that we could then track with these disease models, and we might classify them into empirical type outputs and intervention outputs. Empirical outputs could include disease prevalence or incidence over time or at specific time points. They could include the reproductive number, R naught, or how close we are, how close the reproductive number is to the persistence threshold of 1. As well as population attributable fractions for transmissions by different attributes such as behavior, biology, or demographics. So what fraction of the cases are tied to one, one group or another group? And then interventions, if we're building interventions like vaccination into the model, we might be interested in tracking how much the intervention does across different scenarios. So the number or percent of infections that are averted, the number needed to treat, so how much scale up we need of the intervention to prevent one new infection, and then direct versus indirect effects, because interventions, just like the disease dynamics themselves, are also subject to this contagious process. We usually talk about this in terms of herd immunity, where people are protected by virtue of others in their contacts that are receiving protection. So there's lots of different software to put all of this together and solve these models and build out the models and solve them and analyze the data for them And here's a shameless plug for my piece of software that does this across the 3 model classes that I told you about before, the compartmental models, agent-based models, and network models. But there's lots of places to start, and you can even build some simple models out in Excel or Google Sheets. Okay, so let's return to coronavirus and talk about models within the context of coronavirus. There are 2 main uses for models within the coronavirus currently. And I think that these can be classified into understanding what has just happened in the world and what will soon happen. And then number 2, figuring out what to do about it. And in the first category, you might call this nowcasting or forecasting. We want to test and evaluate how close we are to the healthcare capacity. So that flattening the curve type of model against the flat line of the capacity. And this fulfills right now critical gaps in the empirical evidence because we don't know what's going to happen until it literally happens in many cases, given how quickly behavior and biology is changing. And then figuring out what to do about it, we might want to test different strategies for disease prevention. So this might include behavioral changes, social isolation, use of personal protective equipment like face masks to prevent disease transmission or acquisition, and maybe in the future, use of this model to test out clinical interventions such as therapeutics or preventative treatment like vaccines as these things come down the clinical trial pipeline. So here's one example of a mathematical model for a behavioral intervention, specifically within Wuhan, China, which was clearly the source of the initial outbreak. I'm just showing you this model because this highlights the key structure of many models that we see within the coronavirus literature now, where there is a movement across susceptible, exposed, or latent stages, and then a stratification into infectious stages that are either symptomatic or asymptomatic states, and then a final movement into recovered state. And this ratio of symptomatic to asymptomatic cases is a key question that models have helped understand and tried to take new data sources and figure out what could happen if that ratio were different. This particular model has a nice feature that it incorporates some pretty robust location specific, so like home, work, school, and other locations, contact patterns that are variable by age. So these are age contact matrices that are often informing many transmission models, and these are in different locations, and they're also tracking how those contact patterns changed before and after the epidemic outbreak in Wuhan. You can see the intensity of those contacts was reduced substantially, but the structure of who contacts whom also changed overall in terms of the age stratifications. And I think it'll be critically important to incorporate age going forward into these intervention models, as distancing interventions might be relaxed for different groups that are less at risk, and that's clearly going to be related to age and aging. Going back to the Imperial College model, again, I showed you the results, but let me just tell you about the methods. This is an individual-based model, which is a synonym for agent-based model, that was originally built in 2005 for a hypothetical global influenza pandemic. And it had a spatial structure to constrain the types of contacts that were possible into households, workplaces, schools, and the community. This level of granularity is really only possible with an individual level model like this. It used a synthetic population approach to generate these contact patterns. And as I said, it was developed in 2005, and right now it's a little unclear of what the data sources were updated over the past 15 years since this model was originally built, because some of the assumptions of the model and the model code have not been released still to date. There's an update to the Imperial College model just last week that expanded the original model. Remember that projected upwards of 500,000 deaths within the UK down to around 20,000 deaths, I believe was the revised estimate, and had a projection of upwards of 60,000 deaths that were averted so far as a function of all these massive social changes that happened across Europe over the past month. And you can see this little nice diagram of when that occurred in different countries, and they built these into the model. This is not a more optimistic model, though. It's just reflecting the reality of the changes that have occurred. And if the changes to behavior went back to normal, we would get these more dire projections again. Many models have specifically focused at this point on what types of social distancing and how long the social distancing has to last to make a meaningful dent in the epidemic. And this particular model from Harvard looked at whether a pumping the brakes approach, so some sort of repeated social distancing, say for a couple weeks at a time, on and off, could impact the overall trajectory of the epidemic. And this type of strategy keeps the cases below the critical care capacity, which is the horizontal black line, but it doesn't lead to a long-term reduction in cases due to reemerging outbreaks. They go right back to normal as soon as the brakes are released, right? And we go back to normal social contact because of this reemergence of outbreaks. Some models like this model have looked at this type of contact pattern within the outbreaks, not in cities, but in other contained environments like cruise ships. And the R0 that was estimated from this model was exceedingly high, upwards of 15. And you have to consider that R0, again, is a function not just of some virological property of coronavirus itself, but of humans and how humans come into contact with each other. And that can differ dramatically in different environments. And in cruise ships, before massive interventions start that reduce the rate of contacts, that level of contact patterns is very high. And so the R0 value that summarizes the overall speed of the spread of the epidemic is also going to be high. They introduced mitigation strategies onto this cruise ship relatively quickly in a matter of a week and a half or so, and it also dramatically reduced the estimate of the R0 value too. So here's some considerations in distancing models that you might see in the news and the literature. Many of these models assume a large, well-mixed population. This is a core assumption of compartmental models. They allow for subgroups, of course, say by geography or age, but the contacts don't have any memory. So the contact is possible within a group or across the groups at each time step. There's no memory of who you had contacts with in the previous time step. And that might not reflect realistic types of social distancing that are out there. There's also within these compartmental models no stochastic extinction that might occur within small sub-epidemics, say at the neighborhood level or the household level, where the epidemic could die out over time, just as a random phenomenon. I think we'll begin to see that in certain cases in communities that have followed these distancing policies. Distancing instead is implemented by just turning down the contact rate in many cases, so limiting the rate of contacts from what it was to some lower value. And again, this might not reflect the type of distancing that actually occurs in the real world. Future models are going to explore lots of variations of behavior related to who contacts who and for how long, potentially by age and population density. And finally, we should talk about the IH&E model, which came out in the news over the past few days, which is not a mechanistic model of the form that I've been talking about, but a statistical model that replicates the epidemic shape of what happened in Wuhan, but it's fitted to local US death rates. So kind of like what gets things going at the start. And everything in this model assumes the same level of social change as what happened in Wuhan. That's probably extreme and not realistic. There are no mechanisms for how or why the epi curve changes over time. It's just following the general curve that we saw elsewhere. And it assumes only the strictest social change happened. It doesn't also incorporate epidemic reemergence or seasonality. So I would really be skeptical of this model and what it can say about coronavirus in the longer term. Finally, I'll close and just discuss briefly about how some of these modeling findings have been used and interpreted in the literature. Overall, modeling research, like coronavirus itself, in a sense, has gone viral. And this is driven by an unprecedented speed and quality of the modeling, or sorry, quantity of the modeling research we haven't seen before. In part, this is facilitated by easy sharing of preprint papers that haven't gone through the full journal publication process. Modeling also is a research activity that largely depends on secondary data, so data that other people have collected and computer person time. And this might be less affected by academic closures that impact bench science and clinical science that we're already seeing at Emory and elsewhere. And with this, much of the world has become interested in modeling because this is the research that's being pumped out right now. In lieu of research that can be answered by these other scientific areas, modeling fills this key information gap. But good models are informed by good data, and models informed by more data can give more precise answers. And this combines to create two issues, I think. Number one, a lot of armchair experts in modeling. So people that are just really interested, a lot of people for very good reasons, but don't have a lot of experience or expertise in this area, getting interested in building out models. So we have a boatload of models right now that are available online, many of uncertain validity or quality. And this creates a problem itself for the translation of the modeling science upwards and outwards. So here's another model that got a lot of attention, so-called Oxford model. This model was fitted to the death counts that were occurring in the UK and asked the question, what could have generated the death counts with respect to what amount of people are susceptible in the population, and when did the disease first get introduced in the UK. And this can either be generated by, say, a high proportion of the population that's susceptible and a late introduction, so something that has happened very recently, or a low proportion susceptible and an earlier introduction. So there's a very wide range of possibilities that the authors explored here, and a lot of uncertainty of the inputs, but the authors just wanted to, in one sense, motivate and call for more testing data to inform policy and build better models. How did the news interpret this? The news interpreted this by looking at the light yellow line here and saying that half of Britain could already be infected by coronavirus. Okay, so simply one scenario out of many, one interpretation of an imprecise parameter that was pulled out as the key headline and finding. That's not what the model was showing, but that's what the headline was about. Modeling science is high stake politics right now, and we're seeing this every day as new models are coming out and as they're being presented and used by politicians and public health policymakers. And with this, the science of modeling has become political as well, based on the very high stakes economic consequences of all of the social changes that are going on in the world right now. And one response might be such as President Trump's not to trust the numbers, to have a hunch that they might be smaller than what the models are projections. And another response might be to say that what the model projections are projecting are inconsistent with quote unquote our experience, even though we don't have experience of what's going to happen in the future. A lot of these messages are driven by wanting and needing to reassure the public that things will get better. So I'll end with this side and just end with the anecdote that all models are wrong and some are useful. So what does modeling do? It attempts to really meld data and theory into a system that helps explain the world past, present, and future. And this depends on data collection and theory development as model inputs. The data can change rapidly, and so models might become wrong rapidly too. And that's okay. COVID models have provided information about what has happened and what to do about it. But like vaccines, they prove their utility if nothing bad happens. So if these worst projections, say in the US of 2.2 million deaths, never come to fruition, we might say the model is wrong, or we could just interpret that we actually took the model seriously. This depends on the accurate translation of modeling to policy. This does require some non-experts and non-modelers to evaluate some intricate details of modeling. This is usually the role of peer review and scientific commentary, and this is spread out over a lot of time, and there's a lot of academic debate about what's the right way to do things, but we don't necessarily have time to do that right now, especially as models are filling the news gap. And so for right now, I would say for non-modelers out there, just understand that what the newspapers and politicians find useful from models might differ from scientific and public health principles. Thanks for your attention, and as Dean Hicks said, I'm happy to take questions at this point. Thanks very much. I'm going to stop sharing my screen so I can see that Q&A. Okay, let's see if I can figure out how to do this. Okay, so the first question asks, is it possible to have second or third waves of the virus occur sometime is it possible to have second or third waves of the virus occur sometime at the end of the year once the first wave is over? Yes, I think this would, let's see if I'm, okay, I think I'm answering this correctly. Yes, this is exactly what the models are projecting. Even without changes to behavior in the long term, we're going to expect some cyclical variation in the models that follows the typical influenza patterns of seasonal variation in the models that's driven by the geographic spread of the disease across the world, reemergence of the outbreaks, and so on. I think what we're concerned about principally, and most of all, is the changes in the different behavioral strategies like social distancing as those are turned on and off over time. The second question, which measurements should we be watching to track our success with handling the crisis? The number of cases over 100,000, rate of new cases should be focusing on county, state, country, state, county, city, or neighborhood levels. Yeah, I think this depends really on what the research question is and the public health priority is. And it's probably going to depend on what the person who's doing all this tracking, where they're coming from, whether it's from the CDC and assigned to do it nationally, or at a more local level. Right now, there are many different groups that are doing modeling and doing these projections at multiple scales using lots of different methods. It's hard to keep track of what the different methods are and what the model findings are. I think that that's going to be improved over the next month when there will be more systematic synthesis of the models and what they're finding. Maybe today was just, and my talk was just a little preview of that, but there'll be much more. But I would say some of just the surveillance data that we're seeing at the national level in terms of the case rates and the case rates relative to the case rates relative to the healthcare capacity are the most critical things. Let me go down. What are the challenges do we face with data collection to feed the models? That's a good question. I think that there's quite a lot of biological uncertainty and clinical response uncertainty to how the natural disease dynamics of coronavirus still work, even though we have a lot of data on this so far. And one example of this is the ratio of asymptomatic to symptomatic cases and the amount of infection that occurs in asymptomatic infection to symptomatic infection that we're seeing. There was just a report out today that tried to quantify this in lots of different settings, and there's a huge range of variation that's driven by how systematic testing is in different settings. So in some Scandinavian countries, the level of asymptomatic transmission is very low because they just know everybody who's infected. That's one. And the other challenge with data collection, I think, is related to contact patterns. These are really challenging things to measure in this rapidly changing world and environment where the behavioral response to this pandemic is very heterogeneous and again, rapidly changing. Pull off. Okay, so the question here is about the one particular model by this set of authors that's looking at the changes in the latency duration. I have not seen this model, so I can't comment on it particularly. How many cases should we expect to see accounting for the asymptomatic cases in a population? Just want to make sure I'm getting the notes right from my moderators. Okay. Yeah, so I briefly mentioned this before. This is a key uncertainty, the level of asymptomatic infection and transmission at the population level. This also varies a lot by, not just by country and the level of case surveillance and testing that's occurring at the country and local levels, but also based a lot and varies a lot by age as well. I think this is a key aspect. As you note in your question, the age demographics I think are very important. I think you'll see more and more models that are exploring this. There's one model by James Shea, which is also in Harvard, that looked at some of these phenomenon in some detail. So I can track down the article for you if you contact me later. Okay, got a lot of questions here, so I'm just kind of looking at different ones that are not redundant. This is a good question. How quickly does a model go out of date, and how often do you find yourself making new models? I think that, like I was ending on towards the end of my talk, the speed of modeling, specifically related to the coronavirus outbreak, has just like dramatically increased the speed of modeling research. And many people are not even going so far to have these full-scale models, these full-scale complicated models that go through multiple rounds of peer review in journals, and instead putting the best that we know up on like preprint servers to give the public and the scientific community some sense of what the model is doing and what it's projecting. And hopefully, you know, there will be time again going forward to build out further details of some of these models. But that also makes it really challenging to evaluate the quality of many of these models at the same time. How often do we find ourselves making new models? I mean, ideally modeling should be this continuous process where we're updating the model inputs as new data are becoming available, and we're adapting the presentations, the projections from the models accordingly. I think we saw that with the case of the two versions of the Imperial College model that I talked about. The initial case was this like do nothing scenario. It's the leading case, 2.2 million deaths in the US, 500,000 deaths in the UK. That projection was then reduced downward to 20,000 deaths in the UK, but as a function of all the dramatic social changes that occurred. Okay, so that model was revised in a matter of, you know, a couple of weeks to provide some updated projections. I think that's pretty commendable. Okay, so here's a question. In order to turn down the contact rate as mentioned in the presentation, what is your opinion on a nationwide shutdown in the US similar to what other countries have implemented right now? I think the empirical data, not just the modeling data, have shown that the size of the contact restriction makes a dramatic difference in terms of the magnitude of disease prevention that can occur, with the most extreme examples being in China now, where the contacts are restricted most greatly. Going forward, I think that the types of contact restriction that are going to realistically occur in other countries like the United States that might have different approaches to following political directives and different responses economically to these directives might inherently depend on very structured type of social distancing and other types of contact tracing of symptomatic and diagnosed cases on an ongoing basis, as opposed to a full-scale reduction in the contact rate. And I think that more models will be able to answer these types of questions going forward. We're trying to do so in some of our network models currently. And hopefully that will provide some new options in cracking this tricky problem of how long the social distancing policies have to be implemented. Let me just scroll through. Okay, so here's a question. Asking about the IHME model, it seemed like a month or so, things just go back to normal, almost no mortality. Am I reading it right? And if so, how is it possible that we go back to normal in a month or two? Good question. And again, this is not a mechanistic model in the same way that some of the, in the way that most of the models that I talked about today were, that involved this mechanistic process where the incidence of disease is emerging into the population and re-emerging into the population as behavioral changes are happening. There's nothing in the IHME model that has a counterfactual. There's no behavioral change in the model. There's simply a reflection of what happened in the setting like Wuhan, where that change occurred, and the shape of the epidemic that followed accordingly. So it goes up, and then the changes were implemented, and then it goes down, okay? And that's all the IHME model is saying also, and assuming is the case. So it's not capable of saying anything about the reemergence of the epidemic if those changes are relaxed at any point in time. It's just a curve fitting exercise. So there are a lot of caveats with that model. So Dean Hicks, we're at 8:30 now, and there are a few more questions, and I'm happy to go through some more of these, or I'm not sure if we have a particular time frame for stopping.
Thank you, Dr. Jenness. Why don't you take a couple more questions? I'd love for you to answer the question about what work is happening at Emory on models. Are you using your Epi model on COVID modeling, or are other colleagues trying to model this disease and try to find a way out?
Yeah, good question. So there is some increasing work on COVID modeling that's happening at Emory by a couple of different groups. And I can tell you a little bit about what we're doing in my group with some collaborators in the epidemiology department currently is using Epi model to build out these network models of different distancing strategies that again are trying to replicate real world patterns within dense social contact networks like we see in cruise ships. But these also might be the same types of networks that are relevant and reflective of other dense social environments like schools, nursing homes, and prisons, and elsewhere. So what do we do about the prevention of disease in these types of settings? This is kind of my research interest, and hopefully my contribution is to try to tackle this social distancing question in these types of settings rather than the full population setting. And this has really to do with the question of how many persistent contacts people have over time and coming back to the same contacts within the same environments over time, and then how long those contacts are lasting. Can we change either the number of ongoing contacts, what we call network degree, or the duration of those contacts in particular settings to be able to tackle the social isolation question? So that's one example, and there's some others at Emory as well.
Well, thank you very much. I know that there are a number of questions and students with real curiosity on this issue, and you have really challenged us tonight. I know that you're an Emory colleague, and I looked on the web and could find your email address, so I'm sure that our students could if they had follow-up questions. But I think we promised that we'd do this for an hour, and I think we'll stop. We will make this talk available to other Oxford Studies students on the Canvas site for that course. That was one of the questions. And I think for now, I just want to say thank you. Thank you for the work that you do all the time, and thank you for your talk tonight to help us understand this truly vexing virus. And we certainly hope that your work will help us to understand it better and to address it. So thank you very much.
Yeah, thanks for the invitation, and thanks for everybody for tuning in.
Wonderful. All right. Well, thank you, everybody. Stay well, stay safe.